Hello. Hi. Good morning, all, and welcome all to the launch of our new threads in our forte. Just a brief introduction about the company, Aesthetic Zone. We are three pupils, Nishikant Sahu, Aditya Malik, and me, started the company in 2018, and almost we have completed 8 years now. And we have started from Delhi and Mumbai in 2018, and right now in 2026, with all of your blessings, we are available in Pan India. Even we are covering a small part of that Kathmandu only, that is Nepal we are covering. And our vision is to inspire confidence through safe, sustainable and innovative beauty solution. Our vision is a world where beauty is inclusive, ethical and empowering. Behind every formula, there is a passionate team, technical team together. We blend innovation with elegance. And today we take another step forward after listening to all of your needs and studying the latest beauty innovations. We are thrilled unveil the new product that is Infinite Threads today. And we have Dr. Luca here and Dr.Amit Gupta, who is our trainer, and he has almost vast experience of plastic surgery. We have started our journey with a single product that is Mint Lift Threads in 2018, and slowly we have increased our forte in our bucket, that is numbing cream, Magnifica. These are the Mijo solutions, and Infini, that is body filler. Then we have introduced Filmed, Art Filler, and we have NCTF also in that forte. And Aphrodite thread also, that is PLCL. Right now we don't have that Mint Lift. We have replaced Mint with the Aphrodite PLCL. And now we are going to launch that Infinite Threads, that is semi-permanent threads. And our next product, which we will launch in the next April, that is On My Pure Skin. These are the collagen shots. Again, these are in anti-aging segment, and normally whatever the forte we have, normally we believe that without training we can't grow. So these are the some glimpses where we have done training in different all over India, different states like Jaipur, Rajasthan, Jaipur, Mumbai, Ludhiana. This one is Ludhiana, Gurgaon. Different states we are doing trainings. These are again some glimpses of trainings, and even some international conference where we were attending in class. And most important point, doctor, there is a foundation, Chow Foundation, who support for the acid victims. So indirectly we are, whatever the profit is there, is some percentage of that profit we are supporting to the Chow Foundations. Our mission. This launch is more than a product. It is a promise to continue empowering you with beauty that feels authentic, sustainable, and timeless. Thank you for being part of our journey, and welcome to the future of beauty and aesthetic zone. Thank you, doctors. So I would like to request Dr. Luca and Dr. Amit Gupta just to launch our that Infinite Threads. Dr. Luca is from Italy. Welcome on board to Dr. Amit Gupta. Yeah, thank you, doctor. So just launch of our threads, just pick that one. Thank you, doctor. Thank you for your presence. Thank you all. I would like to request Dr. Luca to for presentation. Dr. Luca.
I'm honored to be here, and I present my present my technique, the way I think is the best for me to use permanent threads, the infinite threads. I will try to tell you something new, and I apologize for my bad English. I will speak slowly, and I will try to be comprehensive. I ask you to think about something that is really new. So forget what you learned, forget what you know about threads, forget your experience with previous threads that very often are not so good. Now, today we speak about the HDS, the high definition mass plus thread lifting, a new method for a reliable and natural face and neck lifting. You are all plastic surgeons, this is the right presentation for you. It's innovative, it's really innovative for the lifting. It is an alternative, it's, I think is something that can be an alternative, a real alternative to a deep plane surgical facelift. I'm a plastic surgeon, previous I made deep plane facelift with the embarkation of the mass. But it's different, is according to me, is more natural. Just a few cases to show you the potentiality. This is a 1 year control. This is a lifting, but is natural, just threads, just HDS, just high definition mass. Okay, is long lasting when you use a number of threads that is enough to maintain the result. Okay. Also the definition of the mandibular line. This is an HDS plus. Plus means that the original technique is just with threads, no? But we will see. We can associate. In this case, lipofilling, and this is 3 weeks after, so I can show you the yellow spot that are the side of the lipofilling in the tear trough, as you can see. And also I very often manage that in the deep medial cheek fat, in the superficial cheek fat. May I have a light? Light to a point, yes. Maybe this is a point, but I can use it. Okay. No, we haven't. I use the fat in the also in the temporal and also in the superficial temporal lodge, and also in the parietal area, like in this case. And this is another case of HDS plus. In this case, she's a beautiful 57 years old woman with you know, the usual signs of aging with not only the nasolabial folds, the marionette, the jaw line, also the platysmatic band 2 centimeters of real platysmatic band, and beginning of the malar bound. I use it also in the malar bound. I stay with the threads just a little more close to the orbital rim, and I think is exceptional for the malar back. So I made an HDS thread lifting plus. In this case, there is a little amount of skin in excess, no? And so I use threads, no fat filling, but a micro lifting. Micro lifting means that I don't do any dissection. I just remove the skin that is in excess, because I use the threads with some threads are with a vector that is not completely vertical, but is like in the usual lifting towards the ear. And this is the day after. This is my assistant that is much more better than me. Oh, perfect. And she showed the patients in the morning after the threads. You can see the exit point. And I show the case of immediately after. Okay, there is edema, as you can see, but no way, in the lifting is not possible in the usual lifting to have a situation like this the day after. There is the scar, not the scar, there is the incision to remove the redundant skin. That is a little incision because it's not a real lifting, just a micro lifting. And the malar, because the reduction of the malar bound, because I used one more threads close to the orbital rim, and so you can grasp the orbicular muscle and elevate. Oh, and this is one of my first case with 7 threads, and we have 2.5 years of stability results with fat, HDS thread lifting plus with fat. So this is to show you the potentiality of these threads. I use the threads before these infinite threads. I used the silicone threads, permanent threads, but they were elastic, so they were not so good for me to have a stability of result. I used a lot of course, of threads absorbable, but I think we must really think about the facial and neck aging causes, because if we understand the patient, that one patient is different from another one, we can manage the best solution for him, and that is not always the same solution. So, according to me, the main important cause is the gravitational ptosis. We live the tissues fall down. It's the main consequence of the fact that we live. And the hypertrophy of the adipose tissue, especially the deep medial cheek compartment, there are a lot of cadaver studies that explain how much the fat, how much is the fat reabsorption of the deep medial cheek compartment under the mass, and of the superficial temporoparietal compartment. This is why very often I associate lipofilling at the end of the procedure in the deep medial, that is under my threads, and in the superficial, that is above my up of my threads. The genetic profile, of course. There is someone that is lucky, someone that is less lucky. And the lifestyle, there are a lot of people that are healthy people that is not so healthy. And the muscle, the loss of tissue elasticity. This is the point, the main important point if you perform a facelifting. You think about the elongation of the tissue. For me, it's not so always so important. And now, before I thought that when we became old is a question of elongation of tissue, of stretching of tissue, but this is not always. The muscle hypertrophy is a question. If you see actors, they are most beautiful because they do a lot of gym of the muscle of the facial area. The depressed people is always, most always with apoptosis because they use less the muscle. And the bone reduction, but in old patient, this is not a problem in usual patient that we treat. So, surgical lifting, of course, for us the best option, of course. But when we decide for a cervical lifting, we assume that face and neck aging as the consequence of tissue elongation, as just I said before, tissue stretching. So the solution is to remove the skin excess, the only solution of the surgical facelifting. But it isn't. So we pull tissues as tight as possible and remove skin as much as possible that is not in excess, is mainly ptotic. After surgical delamination, we pull and accumulate, of course, in front of the ear, so we are obliged to remove it. But the consequence is that at the end of the surgery, the tissues are firm, with no movement. If we are good surgeons, we have no movement. So we try to pull them, no? But there is no movement, and this is not natural. But the ptosis is due, another question, due to gravity, is vertical, is not oblique. So the vectors towards the ear in the surgical lifting are not so natural. But do we really think that the lamination, an extensive delamination, is without consequence about the skin healthy? We destroy 1, 2, 3 times. We destroy the vessel, the vertical vessel, and demand the oxygenation of the skin just to the axial vessel. Maybe it's not the right thing for our tissues. Not always. This is me, my daughter, my mom. So we don't have the problem of the genetic differences, just a few. And I show you just what I said to you before. When we are surgeons, so we perform facelifting, so we want to have the maximum stretch of the tissues, and at the end of the surgery, the patient is with the tissue that are firm because we were good, okay? So, according to this way of thinking, my daughter should be firm, me with a movement, and my mom with a loss of movement, with a lot of movement. The maneuver, you well know, is the same. When we perform a facelift, we start. And as you can see, we move in exactly the same way, 2 centimeters, almost the same way. I don't know if there are differences of a few mm, but it's the same. So I think we should think about a shift about our scientific paradigm, to think about it. The causes, according to what I said to you before. Loss of volume, okay, genetic profile, thin people, healthy people, a lot of healthy people are with loss of volume when become old, when they grow up. The gravitational ptosis, age, tissue thickness, the thick tissue fall down much more than the thin tissue. The genetic, the behavior lifestyle, the depressive mood disorders, like I said you before. The loss of elasticity because of wrinkles, so genetic, lifestyle, sun exposure. So all tissues lie down immediately, and you know. The analysis of signs of aging must be done very carefully. Failure to analyze carries the risk of overfilling or excessive pulling. The techniques that we know in the state of art, the face and neck lifting with SMAS plicature or embricature, fat grafting, the filling, or whatever, energy devices, radio frequency, laser, microfocus ultrasound, absorbable or permanent threads, and this technique, the HDS, thread lifting. Plus, because we can use the permanent threads, the infinite threads, just infinite threads, but very often, as I said before, the aging processes are more than one, and so we can use the fat grafting if necessary, the microlifting, as I showed you before, and the skin resurfacing with energy devices. Sometimes the skin is a demanding problem. So the main problem is not the ptosis, but the loss of elasticity. So we can use CO2, laser, Dermapen, Morpheus, and treating the relaxation of the retinacular cutis and the accumulation of fat in the neck with the radio frequency. Now I use Ignite, that is, I don't know if India you use, yeah, okay, it's a good device. Sometimes. This is an animation in which I say that before, now I can use Ignite, because before I had the face tight, but it was a radio frequency with also the external cannula, and I had the problem that I lose the drone. For me, the drone is essential when I perform this kind of. So now I can use the Ignite, that is one cannula inside, and it's better for me. Then I do the HDS, this permanent thread lifting in the SMAS, and at the end I do the lipofilling in the area that in which I think that we have lost fat. Something about these threads, maybe after we will speak more about threads. Threads are made of the same materials. The materials are silicone and polyester, are the same materials in since 60 years. The problem is not the silicone. The problem of the silicone is in the mammary implant. The problem of the silicone is if the silicone is liquid. So we have problem. The mammary implant because of the texture of the capsula, so contracture, the problem of the gel, if we have a rupture of the prosthesis. This is solid silicone, is biologically perfect, like we use in prosthesis of the ankle, of the knees, whatever. The threads are with a core in polyester that is essential because this thread hasn't to this thread doesn't want to be elastic, is firm, and this is essential to have a stability of result. So we have a core in polyester. The threads are thin. This is another essential condition, 1.4 mm, and so no patient touch the thread if you are in the right plane, of course. There are 4 cogs every 1.5 mm. The cogs are effective because they don't move. They are not reversing, are conical, so they are not dangerous. The tip is blunt and oriented with an 8-axis cooking and a 45-degree rotation. So in 1.5 mm you have 8 threads in 360 degree. You cover all the 3-dimensionality of the tissues. The cogs are gentle for the patient because of their structure in flexible silicone and the rounded tip, as I said before. This is just a demonstration with the quantifier that is machine, photographic machine, just to demonstrate the movement of volumes without any volume that is addicted. You see in the red there is more volume and the vectors, quantifier show the vectors. I used just threads in this patient, and it was a mistake because there was a lack of fat, but she didn't want fat. So, something about the operative method. After I will show you the videos, but you know, there is an artistical part of this method. No, the drawing of the thread path is the artistical part, and is different from patient to patient. You can have some suggestion, okay, from me, but you will be alone to design, to make a drawing, to make the operative plan, and the number of threads and the orientation of threads you will decide in the day of the. It's just less standard disabled than a deep plane facelifting. But the drawing is essential, and is essential that is personalized, and is essential a picture, because if we will have to remove it, the threads are removable, but because they are violet, because they are visible to ultrasound, but if you have a picture, it's better because you know where you put the threads. Operative filmmaking, assisted anesthesia. Oh, in Italy, I think also in other countries, you can put thread in your office without anesthesia, just local anesthesia. But according to me, it's a mistake, because the threads, the function when you put just a little amount of anesthesia. So the anesthesia is intravenous, because the threads are firm when without liquid. In liquid you can move them. So if you use a lot of anesthesia because you are thinking to something else, because you want to manage all the problem in without just in local anesthesia, maybe at the beginning the result is good, but the liquid still remain when the patient go home, and probably in the day after the thread will lose some of its power because of I think that a lot of colleagues of mine do this mistake. Insertion of the blunt needles in the face and neck with different curvature. In the set you have 4 blunt needles, but you can manage these blunt needles and to design the curvature that you need to reach the result. At the beginning, I insert sometimes in a subcutaneous plane when you have thick tissue, but if the temporal tissue is thin, I do under the superficialis fascia. In the face, at the level of the zygomatic arch and bone, the needles are inserted under the smash. Under the smash means under the smash, not deep, superficial. There are anatomical structures that you need to know if you want to do this. The retaining ligaments, okay? Whose grip guarantees the correctness of the plane and its stability. If you are in the right plane, how can I know that I'm in the right plane? Because I pierce the retaining ligaments. They are hard. I feel it's a closer technique, but it's not a technique that is not, is an anatomical technique. And it's much more anatomical than a deep plane technique in which you can see what you are doing. Here you have to imagine, but you have to feel that you are in the right plane because you pierce the retaining ligament. In the neck, 2 threads per side pass through the cervical ligament. It's not always necessary because you know that you are in the right plane because you pass under the platysma muscle. So you are in the right plane and you are under the platysma muscle. And before crossing each other. And now I use one more thread in the subcutaneous plane. This is demanding. Someone is not comfortable to use the. This is my technique, but this is not the Bible. You can use what you want. This is what I do. The final adjustment of the tension with the patient in the sitting position. This is essential. You can't finish the surgery with the patient. Okay, after. This is an animation. The insertion point is in the temporal area. Then I put, the first is under the orbicularis muscle. The second one sometimes pierces the retaining ligament zygomatic. The third, of course, the retaining ligament. The fourth, 5. I use now 5 threads. And as I said before, in the neck, the cervical ligament is between the sternocleidomastoideo and the platysma. Okay, if you pierce it, you have much more stability, but it's not essential. But you must, in my technique, be under the platysma muscle. This is also a cadaver lab in which I show you what I said you before. So this is the zygomatic ligament and the masseteric ligament, the parotideus ligaments. And if you pierce them, you are in the right place. And if you pierce them, the thread is firm, that you can pull as much you want, and it never lose his power. And the threads, as you can see, are under the smash. It's the plane of the smash, this, okay? And it's at the beginning can be not so easy, but it's We are in the neck, and we did the same things in the neck. Obviously, you must manage the problem of the not the carotid, but the jugular vein. So, we come back to my first patient. 52 years old, moderate past phase ptosis, moderate platysmatic bands. You know how to I always, with my patients, use to do this maneuver to understand if in the fat you have excess of fat, you have a loss of elasticity of the subcutaneous tissue, or is a problem of platysmatic band. This is essential, no? In this case, we have the platysmatic band under the fat, under the subcutaneous tissue. I'm starting with the platysmatic band. If you have this problem, you can manage with threads in the subcutaneous tissue without losing the connection between the subcutaneous tissue and the platysma. You pull the subcutaneous tissue and the platysma is pulled a few, but it is heavy, the platysma, so it comes back at the beginning in a few months you lose the result. So if you use the threads under the platysma, you have a stable result. According to me, the neck is really a passage of this technique, because the threads have the possibility that the possibility to maintain the power in the middle part of the face. That is not possible in a usual lifting unless you delaminate in a very aggressive way. No, you know, when you perform face lifting, the best result you have in the jowl, less result in the marionetta, less result in the nasolabial fold, power result, unless that you cut and you do the platysmography, or you do an extensive dissection and you perform. But the threads permits to reach the central part, the central area of the face without lack of power. This is simple, 6 threads per side, and now I show you. The artistic part is this design. This is a methodic, boring part in which you have to put a little amount in the right plane of anesthetic. Little, as I said before, a right place, because otherwise there is pain, the patient feels pain. Okay, this is a J technique. There are different techniques, W, J, there are different ideas. This is an important part. No hair has to be buried, otherwise infection. My infection is the worst collateral effect that you can have. So, attention to the entry point, attention to the exit point, attention at the end of the surgery. Here I am under the platysma, and here I cross with the contralateral one. Okay? There will be a video that is a little more comprehensive. At the end, I pull as much I can with the maximum strength I can. At the end of the surgery, I have to, the final result. The final. If you leave the impulse, probably the impulse won't disappear. I love these threads because they are stable. you don't lose effect, so you don't lose neither defects. If there are the defects after 2 weeks or 2 weeks, when the edema, the swelling is minor, you will see much more the dimples and the bulges. So at the end of the surgery, no defects. This is the result as I showed you before. It's natural. It's a completely natural result. Sometimes, if you move the tissue, you can move the tissue. Not like in the facelifting deplaning, in which very often you can't move the tissue. My daughter, I can move the tissue of my daughter. Okay. 50 years old patient, moderate ptosis of the mass in the face, moderate medial platysmatic bands, normal thickness. We have to speak about the thickness. If you are in this mass, you don't need to have a thin tissue. It's not a problem because you are in this mass. It's a plus thin tissue. When you think about threads, usually you say, I prefer thick tissues because of the problem of visibility. I prefer normal or thin tissue because I am deep, so they are less heavy. Normal thickness, okay, operative plan, 6 thread per side, a needle radiofrequency. At the end of the surgery, I performed the radiofrequency. Okay, and you see, because the skin is a little more pink. This is the videos. Okay. I prefer the J. I used to do the drone of the cheek area. I decide where to put. There are some things that are standardized, but there is an artistic part. So this is the superficial cheek fat compartment. I put 2 threads in the upper part and in the inferior part of the superficial cheek fat compartment with a J technique because it's more stable. But this is not the only technique. In the web you can find other techniques, other way to draw the patient. The marionette line with a J technique that is less curve, of course, and 1 thread is essential for the jaw line. And then I arrive in the temporal area. Now I design the cervicomandibular angle. No? And this is another important part. You see, okay, the movement of the patient. Okay, this is the pinch test to understand how much fat I have to remove. In this case, I don't remove fat. The platysma band. The maneuver, the platysma. So I draw the platysma, the medial and lateral platysmatic band, because I put the thread under the lateral, and the threads come out of the medial platysmatic band and cross with the contralateral one. If you cross, the threads are firm. There is no possibility to move them. And the thread of one side cross the thread, the inferior thread of the one side cross the superior threads of the other side. The design continues because I have to fix the threads under the scalp. At the beginning, I was deep between Galea and periosteum. Now I'm not deep. So, because when you pierce the Galea, sometimes there is pain, and this is a great problem that sometimes you have to manage for months. So I'm in the subcutaneous space in the area of the scalp. These are the area that I decided to treat with fat, a little amount of fat. It's important to be precise, okay? 2 centimeters from the orbital rim, because I don't need to treat malar bounds. Otherwise, as I said before, I'm the picture. The picture is essential. If sometimes I have never had the problem to remove a thread. I hope I won't have never, but a picture is essential. Okay, the anesthesia is local, but is an operative room. There is an anesthesiologist, and we have an intravenous anesthesia. I use a punch to do the holes, and after I continue the anesthesia with a cannula, blunt cannula, just 1 cc, 1.5 cc, 0.5 cc. We are speaking about this amount, not like in when we do the facelift, bam, 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 we use 30, 40 cc of anesthesia. A little amount of anesthesia is enough. If you are in the right plane, it's enough. The right plane for the first thread is under the orbicularis muscle. You have to know where is the orbicularis muscle, of course, and you feel a little click when you are in the prezygomatic space that is between the preperiostral fat and the SUF. You are under the SUF and above the preperiostral fat, and you reach the end of the nasolabial fold, but you are 2 millimeters before the nasolabial fold, not in the nasolabial fold. If you are in the nasolabial fold, you don't have the result. No, you can worse the result. 2 millimeters before the nasolabial fold. Then the problem of hair, always the problem of hair. You see, my assistant. Then the second one. No, this is the third one. So we have finished the zygomatic area, and I'm towards the marionette line. Okay? Here, when I reach, there is a trick to understand. Like in the high mass lifting, when you are in the zygomatic arch, you push the tissue, and like I do when I want to do with the flap under, no, this mass, I do the same things. I push the tissue, and with the blunt needle, I pierce this mass, and I pierce the zygomatic ligament that is in the inferior part of the zygomatic arch. I feel a click. I'm in the right plane. Yes, look, the same things. I push the muscle, and I do under the muscle. You know, if you do a facelift, that under the muscle is a plane that is without bleeding. It's perfect, the plane under the platysma. Okay? I push the muscle and I go under the muscle. Then I cross one needle with the contralateral one. This maneuver is to see without high speed, but this is just to show you the potentiality and the fact that it's not simple. It's not necessary to do all these things, but if you want, you can have an alternative real to the deep plane facelift, according to me. I push a little, but at the end of the surgery, and just to fix the thread, I'm performing the liposuction, of course, and I'm really strong to pull the threads at the end of the surgery. She's not so good, but now I do all the maneuvers to remove the dimples, and the maneuvers are almost the same. 2 centimeters above the dimples, I'm with my thumb and I push down the tissues. Just to remove the dimples. No dimples at the end of the surgery. And then I perform the last part, that is the lipofilling, and yeah, as you can see, no dimples, no bulges. The lipofilling, just a few amount, 2 or 3 cc. It's not in the deeper to the threads, because it's another area, the deeper. And then I perform the Morpheus for the skin. Okay. Okay. For example, this is a patient with thin subcutaneous fat layer. This is perfect for the technique because are not heavy. So it will be stable in years. Perfect like age, like tissues. Just 4 threads per side, just the face and the little face lipofilling. 3 cc in the temporal area. It's perfect, but it's not perfect in the temporal area. In the temporal area, to be thin is a problem because the tissues are thin. But you can, if you are able, you can put the thread under the superficialis fascia. 3 cc in the temporal area, 4 cc in the deep medial cheek fat, 3 cc in the zygomatic arch, and pulsation of lasers. And this is the results 2 years after, and is really natural, really stable. She's very happy. Just 4 threads. 58 old patients, moderate severe medial platysmatic band ptosis, 2 centimeters. When I have this platysmatic band, I cut the platysmatic band before I use the threads. I cut with a maneuver with a silk, and I use it. I use with a closed way. I catch the platysmatic band and I cut with a silk in the 0.5 centimeters under the cervical mandibular angle. I catch the platysmatic band and I cut it with a silk. After I use the threads. So 4 threads per side, 3 in the SMES plane, 1 in the subcutaneous plane, just a neck. I treated just a neck, okay? Because she didn't want to treat the face. And the neck, and obviously, if you treat the neck, you are obliged to treat also the jowl, because otherwise you have redundant skin. And this, at the beginning, I treated just the neck. It was a problem. The neck and the jowl. This is a problem because very thick subcutaneous tissue is quite the opposite of the normal idea that we have about threads. It's not a problem if you use 16 threads, 8 threads per side. I had to use 1 or 2 threads more than in a patient with thin tissues. Of course, the result is very, very natural. The patient is very happy. She is a colleague. You can use also, as I said before, in thin subcutaneous fat layer with fibrosis as a consequence of prolonged subcutaneous inflammation. So I used just more face lipofilling, 15 cc per side, and 7 threads per side, 6 in mass plane, 1 in the subcutaneous neck plane. And this is the result. Always natural result. Always tissues that are not firm. They can move. The result I showed you before. This is when you have this is a case in which, for example, the main cause of aging is a depletion of fat compartments. As you can see, the whole of the eyes, no? Like a skeleton. So I use HDS thread lifting with 6 threads per side, but a lot of fat grafting in the deep medial sheath fat compartments, in the superficial temporal fat parietal fat compartment, and in the orbital rim, of course. You can see the design of the area in which I put but it's not perfect because I put fat also in front of the ear in the parietal area. These are 2 area very important: superficial temporal paria, a superficial parietal area in which I put fat, not only in the deep medial and superficial medial cheek fat compartments. The opposite, thick subcutaneous fat layer and hypertrophy of the fat compartments because of diabetes. And the operative plannings, HDS thread lifting with 7 threads for side and fat liposuction in the lower fat compartments. You can manage the fat liposuction, but after you have to use threads to catch the tissues. Otherwise, you have you can have a flatty face, you can have a redundancy of skin in the lower compartments, and this is terrible. This is now 2 years, because as you know, the fat, the effect of liposuction after, the stability, not also, you have some, the stability of the result. She is my neighbor, so we see each other. She showed, she did this video for me some months ago. After lifting, after cervical lifting, I want that you try, if you can, after a lifting, because you can ask the patient differences after a lifting, and you will see that the patient, so the patient that had a previous lifting is the best patient to operate, because she knows the after of the lifting, and she knows the difference. She will be able to explain to you the differences, maybe better than me. The operative planning, 6-thread 4-side, fat grafting, of course. The result. Another case of a previous facelifting, 12 years before, was operated by the best surgeon in Italy, able to do facelifting, the best, the most famous Italian surgery in the world. And but after 12 years, the effort are finished. And there was another problem that I tried to manage with moderate result, but a little improvement after a scleral show, after a blepharoplasty made by another surgeon on the best one. And so I tried to put a thread 1 centimeter close to the orbital rim to push tissue, just to have much more tissue to sustain the lateral canthus. Obviously, it will be a very little result. So, 13 threads, 6 on the right side, 7 on the left side, 1 more to correct a little post-surgical scleral show. Okay, and a few, a little better result is, sorry, a little improvement of the left side of the eye was reached. Okay. This was the patient in which I couldn't do the lipofilling. There are some healthy people that doesn't want lipofilling because, do you think I'm fat? No, no. Just I want to. But it was impossible. So just threads, and sometimes are not enough. The result is good, but without thread, without axillary. Without, if the diagnosis is also that you have less fat in the compartments, you have to manage this problem. This patient had a medical contraindication to surgical lifting because of a chronic anti-inflammatory therapy. So the risk of bleeding was excessive to me. So I decided for the HDS thread lifting with 6-thread 4-side, fat grafting, and micro lifting, short incision, and removal of excess skin. How can I perform this? Just I push the thread, not always vertical. In the cheek medial compartment are vertical, but here are less vertical, and they do towards the ear. Then they do a sort of angle, but I try to push the skin towards the ear. Then I made the micro lift. This is an immediate post result I made 2 months ago in a live surgery in my country, just to show you that the patient has to be obviously with swelling, edema, okay, but no dimples, no bulges, in a thin. Okay, we speak after about bulges. So, the postoperative effects, edema is for sure, because you are less traumatic than in cervical lifting, but there is the anesthetic, there is so a few days for the absorption of the anesthetic. If you do lipofilling, you can do hematoma. If you do just the HCS, if you put just threads, the hematoma is rare. The hematoma is not so frequent because you use the adrenaline. The subcalaire traction pain is a problem that I don't have anymore because I'm in the subcutaneous space when I fix the threads in the scalp. The collateral effects, line, dimples, bulges. The bulge is not due to edema because we have to understand the difference between the bulges due to edema, and they are in the area of the thread, just in the area of the thread, 5-8 mm, 1 centimeter of edema. These will disappear. The edema that is due to the bulges that are due to a wrong planning are different. Infection, the worst consequence of the fact that you, in 99% of cases, you didn't control, you didn't see hair buried. Parotid gland perforation. You have to manage this problem. No, I hope you won't manage this problem, but it's with Botox. But you know, when you are in the area of the parotid gland, you can't move the parotid gland. So if you put the thread under the SMAS above the parotid gland, it's fixed the parotid gland. So it's not so easy to perform. The jugular vein. Before starting, make the Valsalva maneuver to evidence the jugular vein and draw the jugular vein. When the patient is in the operative room, the jugular vein is more deeper, but you can do this maneuver. You do this maneuver. The left hand is much more important than the right hand because you pinch the platysma and do under the platysma. You don't do this without the left hand. It's a mistake. You do this with the left hand that indicates the right plane. Okay? Contraindication. Of course, with great skin laxity is a contraindication. Big platysmatic band is a contraindication. And great skin elastosis. You have to treat them before perform a facelift. Otherwise, you have an excess, a big excess and big amount of skin with the elastosis. Hematoma. If you have an hematoma, it's possible. At the beginning, I was maniac to reach the masseteric ligament. It's not necessary. You have to pierce, when you pierce the zygomatic ligaments, when you pierce the parotid ligaments, it's enough. There are the masseteric ligaments, but there is also the masseteric muscle. Okay, the masseteric sometimes bleed. And I had an hematoma. It's not a problem. You use a needle. You see the patient the day after, because the hematoma was not in the operative room but in the following day, in the following night. And I made a drainage with a needle. You use a needle, and the blood is not coagulated at the beginning. I didn't have an infection, but a colleague, my colleague of mine had an infection. An infection is always a problem. You have to remove the threads. You have to remove the mammary, the prosthesis. You have always to remove the prosthesis when you have an infection. And the threads are not an exception. So you can use antibiotics, but if you use a lot of antibiotics, you have less infection, less inflammation, but you don't solve the problem. You have to remove the threads. Dimple bulges, as I said before, at the end of the surgery, dimple bulges can't have to disappear, because they will be permanent problem. You can I always want to see my patient the day after, because sometimes I don't see I don't see everything. I try to be precise, but sometimes I lose some defects. The day after is possible to manage all this problem. After a week is much more difficult. Just a last consideration, the role of your assistant. You can't see everything. Is not, for example, the preparation is, you have to remove the hair, so you have, your assistant has to be very precise, like you, for this surgery. I saw a Turkish surgeon that made a shaving of 4 centimeters. Okay, for me, for me it's too much. But just a little shaving in the, not only in the entry but also in the exit point is necessary. After that, at the end of the surgery, I always control. I'm not able to do this with the hair. I'm not so. So I think that an assistant that is able to do this is better for you, because you know, you work in not in a clean area. Okay, this is a part that is very, very important. And another part. Oh. No. Okay. No. No. Just a moment. No. Okay, I wanted to show you this video, but I think it's not possible. Okay. Just to go faster at the end of the video. Is this possible? No? To go faster at the end of the video. No, no, no. Not at the end of the presentation, at the end of the video. Because the video is 4 minutes, I just wanted to go to the end. No? Okay. We are close to the end. I have the photo of the colleague, the Turkish colleague, with the shaving of 4 centimeters. Just a moment, I can't go faster, but are 2 minutes. But this part, as I said you before, is really important, is quite important like the surgery. Because if you see, if the patient is well prepared, the result will be better. You can use gel, of course. I do a preparation with chlorhexidine the day before. The exit points are also important because sometimes we speak just about the entry point, but the exit points are also important because sometimes buried air are also in the exit point. If it's not a problem in the first days, the buried air is a problem after a few months, but it's always a problem. Another things that is very important that your assistant has to do in a maniac way is to control the buried air. I will stress the concept until the end of this presentation because the difference between a good result and a disaster is the buried air. So control that is not a problem if the hair is inside. The problem is if is half inside and half outside. And at the end of another thing that is really important for this kind of surgery is that the patient at the end of the surgery is clean. This surgery is not clean because we can't use the electrocautery. So if we have a bleeding, we will have to manage the bleeding with pressure, okay? But after, we have to clean the patient because at the end of the surgery, the patient is not clean. But we are saying that it's different from lifting because you are the day after this kind of surgery, you are different than from a facelifting. So the difference is also that you can go outside of your house, but if you are not clean, this is not possible. Okay? So, conclusion. This lifting is effective, stable, and safe. Effective because of the innovative three-dimensional disposition design of the coax. It's very powerful. At the end of the surgery, I use a real strength to fix the tissue as much high I can. Stable, are permanent, so are not elastic like the threads I used before. So there is no loss of results due to lengthening, and just because of the fact that are permanent and not elastic, the final results are more accurate. When I used elastic threads, I had to imagine the results after 3 months after the threads had lost 30% of their force, of their strength. So in this case, we have a final result at the end of the surgery that is the final result also in the following months and years. Of course, every year you have an years more, but the final result is stable. It's stable because we have in the deep plane, we are in the same plane of the deep plane. Safe biomaterials that are visible with ultrasound. Oh, I think I think is not a problem. If I will have to manage this problem, I will cut 1 centimeter in the exit, in the entry point, and will search the thread. Because there is a minimal fibrosis. And this is why we have a minimal fibrosis, because the thread doesn't move. It's fixed. Moves just in a wet surface, in a wet tissue, but not usually. So we have a minimal fibrosis. And the versatility of this technique we can use with lipofilling, liposuction, medial platysmographia, removal of redundant skin with micro-lifting, and as I showed you before, with superficial energy treatments or other medical procedures. In Europe, we do a mini lifting academy in which we perform in cadaver lab these maneuvers twice in a year in Italy and Barcelona. Thank you.
Thank you, Dr. Luca. Hope it was a fruitful presentation from Dr. Luca. Any question if you want to ask? Otherwise, we can have a tea break for after that we can discuss. Yeah, Dr. Luca.
Excellent, Dr. Lucas. Myself, Vikram Singh Rathore. So I have a couple of questions, or rather say clarification. When do you decide in a neck the central band, platysmal band need to be severed?
Severe?
Means you cut.
Cut.
When you decide the central platysmal band to be cut. Otherwise, you said that the entire thread should be underneath the lateral as well as the central band.
Okay, the first question, then you repeat. Now I decide to cut always the medial platysmatic band now, because I'm comfortable with the closet technique, with the silk. As I said before, I cut 0.5 centimeter under the prevented cervical mandibular line. So, for example, if this is my cervical mandibular line, I cut just 0.5 centimeter under, okay? My predicted cervical mandibular line, because there will be. And then, when I have cut, I perform the lifting, and I pull the medial arm.
I got it, because that was my question. Because what happens if we are not removing the neck band, central neck band, ultimately the longevity of the result doesn't remain. So that's why you said that now you are following a policy to cut in each and every case.
Yes, in
however
all
mild
cases.
it is. Second question is that if suppose a complication happens, you want to remove the thread. So from the entry point in the temple, it's easy to remove. But for the neck, since you are creating another oblique, does it create a problem to remove the thread?
Yeah, for the neck, right question. For the neck, before you have to cut in the crossing point, and to cut the crossing point, obviously. After that, you start from the entry point that are yeah, okay.
Good afternoon to everyone. Yeah, good afternoon to everyone. And for all those of you who don't know me, my name is Amit, and I am from Delhi. So I'll just tell you very simple, small things, the differences that we see in India. I've been doing these threads for about a year and a half. So I was fortunate enough to travel to Nice in August 2024, and we learned this technique, and it is privilege as well that uh, the gentleman who I learned it from, his son is also here, so he's going to be talking to us also. And wonderful team, great hospitality, and more important, great knowledge of a concept that was very foreign to me. And I'll make a very simple statement here which should raise some bells in your minds as well. So all of us know how to do the other kinds of threads. And plastic surgeons ki ego thodi zyada hoti hai, we all know that. So when the threads were being done, I was like, kid stuff. Amit, 20 years, easy, nothing in it. So he said, okay, scrub in, come. To put 2 threads, it took me over an hour. And by the end of it, I was sweating. My shirt was all wet with sweat because of the stress, the tension, and the fact that this is not easy. So that should ring bells for everyone here. Having said that, when I came back, when I did my first case, it took me 2.5 hours. And my team saw me trembling for the first time. My hands were trembling because it is not easy. To be honest, it is not easy. By the 4th or the 5th case, we cut down the surgery time to about an hour, 15 minutes. Today, we do it in about 25 to 30 minutes. But so, of course, it gets easy like all other surgeries. So the most important point that everyone must acknowledge today is it is very, very different from the other kinds of threads that you've been used to doing. So you have to do a lot of unlearning and relearning. Otherwise, you will land up with problems. Why? Most of the other threads we are doing are subdermal. So we're used to that kind of a resistance-free zone. These threads right from the outset are deeper subsmas. And especially as you go down, you hit the zygomatic bone, you have to step down. Now, how do you step down? The needle is a semicircle. It's a C-shaped needle. You have to manipulate the needle inside the face, making sure you don't go intraoral as well. It is very easy to go intraoral, and that is why it is recommended that we do not give infraorbital blocks. Because you do that, you will numb the patient, the needle can go intraoral, you will never know. And you will only know next morning when the patient says he or she can feel something inside. So that is little difficult. And then the barbs are, if you land up with a wrinkle, God forbid, you land up with a wrinkle, you have no option but to take the thread out. It's not an absorbable thread. So there are ways to prevent that wrinkling, and I will just make 3 humble requests to everyone who wants to do these threads. Forget everything else, just 3 small things. 1, stay deep. If you're more deep, you're likely to be safer. 2nd, learn how to exit the needle. You make one mistake and you'll say, oh God, why was I born? It can be bad. And the 3rd is the hair, which you saw how the hair was being cut. I don't cut hair. Sometimes I do, sometimes I don't. But management of hair, because I've done 51 cases till now. And amongst that 51 is my mother as well. So she's 76. And I've done her procedure as well. So it is safe. So any patient who asks me, is it safe? I say, okay, talk to my mom, this is a number. So the patient does not ask whether it is safe. So hair management is the key. I've had 1 infection. I have no qualms about accepting my problems. So I generally do 8 threads in most patients. 1 thread got infected. We had to take it out, 3, 4, and like we do for breast implants, take it out, let the tissue rest, antibiotics, etc., and then go back and put that again. So it's not tough. The problem we identified was hair. What you will learn as you keep doing this is, if you've got a transected hair inside, it does not matter, it will get dissolved. But if you've got a living hair inside, if it is still attached to a root, it will keep growing and cause a mess. Like a breast implant, the first evidence of infection, please do not depend on antibiotics and heat compression and God and all that stuff doesn't work in this. No God will come to help you. The first evidence of infection, please take the thread out. Just remember these three things, you'll be safe, because surgery you will eventually learn. It is very simple because we are all plastic surgeons, and I think sometimes people ask me, is it really, should we do it? Why don't we just open and do it? Or why don't we keep using what we have? Please remember, these threads are only for plastic surgeons. So we have extreme exclusivity over these threads. The company has a policy, they will not train, they will not give. So no non-plastic surgeon can get access to these threads. And that is a huge bonus for us. Now the reason for that is these are tough to do, and there's a certain bit of anatomy one needs to know. Now I myself do not even know the names of the fat pads on the face. I'll be very, very honest here. I'm not that educated in terms of anatomical names, but I do know what comes where. I have that touch sensation, which we all do. So it's okay if you do not know nitty-gritty of each damn final nerve which grows there, but you should know what is where. That's all that you need to do. So I don't need to talk anything about these things. You already know this. What I'll just see. So in the Indian scenario, some of the problems, some people ask me a few things and I'll just talk about that. One, cost is an issue. It's a huge issue in India. We do not have the privilege of doing as many threads as we like. Patients do not pay. These are expensive. The maximum I have done on a patient is 6, and I have only done 2 such patients. In general, they do not even pay for 4 threads, 4 each side, so 8 threads. It gets really tough because, I mean, an average procedure like this will cost about 3 lakhs. That's what I price it at. You may choose to price it at whatever you like. Someone might charge 5, someone might charge 1. That's your choice. We price it at around 3.5 lakhs. Now, when we tell them, okay, we also need to do a bit of fat injection. Doctor, the cost is going high, please include the cost. We tell them, okay, do a bit of face liposuction, because Indian faces are heavy, we know that. In a heavy face, these threads do not work very well. I've had there was someone I knew very well, someone there known, and I made the mistake of not putting enough threads, heavy face, unfortunately she didn't get a good result, so it's my fault. But in a heavy face, my policy has now become, I will do a vaser on the face, I'll liposuck the face, I'll liposuck the neck, and then I'll pull it. So that's what has become, and even if you have to do a buccal fat or something, it can easily be done at the same time. So we routinely do blepharoplasties, fat injections, along with threads, face liposuctions. I'll show you a picture of one such gentleman. It's very safe in men. In my experience, which is very limited, I do not know if keloid patients can be done or not. We'll have to talk with the founders if patients who are prone to, because the needle is coming out from 4 points on the face, 4 points here, but this is hidden, and 4 points here. The problem are these, so I do not know. Now, the reason I do not know, when you do other absorbable threads, it makes no difference. The problem here is a bit of friction which happens because you're pulling the needle and the thread. Does that friction lead to keloids? I do not know. So let's just wait for the data. Now, I'm not getting into how temp threads and permanent threads are good or bad. The main focus here is the permanent. These threads are done subsmass. So all those of you who do facelifts, simple corollary, can you do a facelift without smass? Can you just do a mini facelift? How long does it last? So that is the answer, whether temp threads are good or permanent threads are good. Now, we do have a patient who I'm going to be doing a live on. I'll make a disclaimer here. Today morning, so she's a gynecologist. She's coming in from down south. She messaged me at 5:30 in the morning. I'm having doubts whether I want to do it or not. So I hope the plan doesn't change. I apologize in advance if the patient cancels out. It's not in my hand. I've tried to convince her. She has flown. She's already landed. She's at the hospital. But she's saying, I have to consult you. So fingers crossed, let's hope everything goes well. So she says, I only want to do 1 thread in the neck. I said, please don't do it. There's no point of doing it, because we all know without the face, there's nothing on the neck. So I'm not getting into this. Yeah, this is the gentleman who had done a face liposuction, neck liposuction, and 8 threads, 4 each on the face, and buccal fat on the same day. So now we all know if I had not done the face liposuction, this is such a heavy face, the threads will not work. As simple as that. So if your patient says, no, I don't have the money, please don't do the patient, because that patient will get really upset and then they'll call me. So I am on social media as being the first person. So when your patient gets upset, mark my words, they will call me. Because then they go onto social media, they'll start searching who did it, they'll find Amit. So please do not do a case if you feel they will not get a good result. Very simple. Very recently, so we had been saying no. See, I'll be honest, I do not have that much of experience in face plastic surgeries as some of our European plastic surgeons do. We do not get that many surgeries. So we were saying no to a lot of patients who had excess of skin. And those huge necks, it's amazing the kind of results. I mean, I've been doing it, but I'm amazed at the kind of results shown in the morning with the neck. I truly believe those results surpass surgery as well because of the longevity without an incision. So you balance the two. Are you okay with the incisions, all that swelling, and are you okay with virtually no scar? Even if it's 20% less of a result, I would happily go for that. Once I get old, I don't want a cut on my face. I'd be happy with 20% lesser results. So if you are in doubt, don't do it. So what we have also started doing now is last week we had 2 patients, we did mini facelift along with threads. So that was also a test that does the thread really go deep. So when we opened the face, we couldn't see the threads. So and I took his help, I messaged him and he guided me. Do this, and that's exactly how we did. So people who have excess of skin, so 55, 60, 65, I think you can do threads because the smarts gets pulled up vertically and then just chop out the extra amount of skin. So it works there as well. So this is a lady again, she's not Indian, this guy is of course Indian. So I'm trying to focus on what we've been doing. This is the next day of surgery, which we expect, so 4 threads. What you will always see, one more thing, there's a difference between dimples which you can remove and the dimples which you cannot remove. Sometimes we will get dimples at the exit, it just takes 5 seconds to remove them. And even if you've forgotten to do that on the day of the surgery, it's okay. Please mark one more point. No patient should be sent outside the city that same day. They have to be with you. You have to see them next day. Because if there's any dimple, you can release them. Because if they go back with that dimple, you are the worst villain in their life for them. Because no one in their country even knows what to do. Forget about releasing that dimple. Now, second, if you have a dimple on the track of the thread, you land up in a soup. Because then, why does that dimple happen? Your cogs have hit the dermis, as simple as that. They're not deep enough. So what do? You have to take it out. There's no option. Now, there's a small difference here. I don't know if I've kept that picture here. There are lot of people will have natural depressions. And usually that natural depression happens just below the zygoma, sometimes elsewhere as well. Your photographs will come to your rescue. I had a patient, 64, 65 from Australia. Post-procedure, she had a very deep depression after the thread. So initially swelling was there, so we didn't really note it. She went back home and then she started sending us pictures, and comments which were not very diplomatic. You know what I'm talking about. We all have faced that. Like, what is this? There's that XYZ, flowery language and stuff. So then we took out her old pictures and then we realized that that depression was there naturally. So you have to note those natural depressions on the face and tell the patient, otherwise your life is miserable. Because one, the patient is paying a lot for it. We all know if a patient pays more, they also suck more blood. So they will suck your blood if you do not tell them. So I'm telling you practical problems because we in India face this a lot. I mean, I believe when a plastic surgery patient signs you up, you become their son-in-law. So you have to do everything that they say. That's literally how it is in India. We all know that. So that is essential for you to know. Mark that, tell them, because if you don't, that depression is not going anywhere. It will get worse because you have pulled everything whatever the little bit of dermis cover was there or fat will get pulled and the depression gets worse. So you have to tell them that. And in fact, more important that mentally you have to take a note of it because when you're doing the procedure, what happens is you see a depression and you'll say, okay, let me do it again. You'll do 3-4 times, but that depression remains. That is because it was always there. So we've had that. We've had 1 or 2 situations where we were a little casual. Okay, this happens. And then the depression doesn't leave. So then we got all the pictures, put it on the TV, analyzed it, said, it's fine. So we just did the procedure. So if there's a 90% chance, of course, we'll be doing the procedure today. I'll show you how deep we go. And there's a certain test that everyone has to do as you get in. So I'll give you a very practical thing of what needs to be done. So some of you will be coming for trainings and Vikas is going to make sure that he's going to come to every city to make sure we get into this. When So all those of you who have done hair transplants know that unless you are in a very comfortable position as a whole, as a body, you cannot do a transplant because you land up with problems. Now, what does comfort mean? Neck in a certain position, shoulder in a certain position, elbow in a certain position, wrist in a certain position. So if you try doing hair transplant like this, you can't do it. And that is exactly what you have to be very, very careful with threads as well. The moment you do this and put the thread will not go. The moment you do this, the thread will not go. And all the ladies here, please get your boyfriends, partners, husbands and start shaving their faces, because without the use of the left hand or right hand in lefties, this procedure cannot be done. Because otherwise, there's a way to do it as well, but it's a little more traumatic. So the use of the left hand and the right hand is essential, and your left hand has to be as precise as your right hand to put these threads. So these are things that I've learned as I've started doing it, and you will not get these instructions online. So note some of them, because the technical part you've already heard. I'm telling you what is going to stop you from doing these threads. Suppose you do this when you're putting the thread, you will not be able to put the thread. So we are a team of 3 plastic surgeons. My other plastic surgeon, so she was doing one case a couple of days back. So while she was doing, her shoulder started rising, her elbow started rising. So I slapped her. So we do that. We keep a sort of a large instrument, one tight slap, and then she gets normal. So you have to be careful in doing that. The reason I I just hit her, gentle hit, was because the lady who came to train me from France, I don't know how many times she hit me. My nurses were like, this guy is tolerating being hit by this lady who's coming from France. And I'm like, no one knows about it. Please don't tell anyone. I know the country knows me that I'm perhaps the most arrogant plastic surgeon, male plastic surgeon in India. So this is another patient. So we can actually get these kind of results in India. And if I had done her neck, she would have been even better. So these are just 4 threads. This is about 15 odd days after the procedure. Next day, so what you can see is the face starts to look a little more happy. I'm not saying the lines will get eliminated. They never do. They get better. And in younger patients, now I've even done patients as young as, the youngest has been 34 or 33, you actually stop aging, retard aging, because it acts like an anti-aging tool. See, if your muscle, so I'm using the word muscle for SMARS or whatever, is fixed, the skin is an envelope. It will shift up, and gradual aging will bring it down, but it is already hitched up. So you are decreasing the physical age of the face a certain number of years, and 5 years down the line, you will age 5 years less. So that's the sort of what I tell every patient. Oh yeah, this is that lady. So if you see this depression, so this is what troubled her, but then it's already there from before. So that is what saved us. Now you can see the jawline, I think she's 65 or so. I mean, a candidate for a facelift, but what we see is she looks happier, she looks younger, more youthful, not too dramatic, because for that we would need neck, we would need a lot of other things. She was very low on her budget, so all we could, I think we only did 6 threads, if not 8, I don't remember. I've started a new technique for the jawline. I hope we can get an opportunity to see that as well. Today I'll stick, if you're doing the surgery today, we'll stick to what is the basics. I'll not do any theatrics today in the OT. We'll just stick with what is basic, because once you learn that, you can start devising your own things. Again, a slightly heavy face, you can get this kind of a look. She's a mountaineer from Dehradun, so you can do that. She's ex-air hostess with Air India, 36 or 35. So what you will see is, you might say there's no change. But when you look closely, you'll find the face is a happier face. The face is more glowing. Everything on her cheeks looks better. On a younger face, you cannot look more dramatic than that. This is a very interesting story. So this lady is, she was very upset after, the only patient who has been very upset after doing threads, the permanent threads. And she was like, you know, I'm really upset with what has happened. I'm like, what happened? You look pretty decent enough. What else can you do? She said, the problem is something different. Earlier, I was doing absorbable threads. No one in my family came to know. now I did this, my husband is saying, what have you done? Why do you look young? Like, is that good or bad? I don't know. But she said, I have now to tell everyone that I've done something. So that is testimony to what is the difference between absorbable and non-absorbable threads. So this, again, a youngish guy. He was my first neck patient as well. Pretty decent. Oh yeah, this is dramatic. So she's about 38, she's from Shimla. And you can now see how she looked, say 2 or 3 days later. And the pictures on the extreme right are from about 6-7 months after. So such a dramatic change in the shape of the face. So I really think 6 months later, a surgical facelift will only be about 20%, even if it's 30% better. There's 3 or 4 days of downtime to this procedure. I think it works. Again, a significant inversion of the facial triangle. Didn't need the neck anyway. Yeah, so this is again, so the lady on the right is the daughter of that lady who had that depression, that Australian one. And the first picture you see how the face looks more youthful. And I think that's what we are totally aiming at. A happier looking face which is more harmonious. Please remember, I do fat injections under the eyes, cheek region in almost every patient. Even if the patient is not paying for it, I still do it simply because it adds to the result. So some of you might see that glow is there, or the cheeks are a little better. So I would feel, even if the patient is not paying, please it's just 5 minutes of our time, but it improves the results a lot. So this is a very interesting patient. So the picture on the extreme left is the one on the day of the procedure. So she got me pictures of herself 5 years back. And then she came to me 3 months later and she showed me the 2 pictures and she said, I look exactly how I looked 5 years back. So this is dramatic. I think this is a beautiful result. Excellent skin quality, an ideal patient for something like this. So you can actually achieve some of this. So now I'll just go on to a couple of videos. I'll run through the procedure. So markings, I don't know if I really need to get into it because I think there was a very, very descriptive, the markings. And the only important thing, please remember again, for the sake of repetition, at the cost of repetition, stay away from the laughter lines, stay away from any line that you see, because we all know that. You can't put anything in the lines. So that's that. Now, there's another interesting concept. If you want a little bit of an lateral eyebrow lift, little controversial, there's a surgeon in Turkey who put this up there's a group of the thread users, the permanent thread users, and they put it up that if you take the thread, instead of taking it back, you take it anteriorly, you will get a little bit of a lateral eyebrow lift. We've had that patient, I've noticed that, but when I discuss it with the founders, they said it's probably because you started little more anteriorly rather than here. So maybe that pulled the eyebrow. So you will learn this as you do. So there are certain landmarks. So I started off with landmarks when I started. Now I do as per what my intuition says. So I'm not too fixed on landmarks and measurements. I'm a kind of a, that freehold kind of a person. I just do what my intuition says and usually works. So I'm, Ankit, दूसरे वाला, अच्छा उस पे, just 1 second. So, okay, so I'll spend about 5-6 minutes. This is a very, very long video. I really want you all to see it, because this is how we actually do it. I'm not going to go very fast. So we start off with a small bit of local anesthesia, 4 dots. All my patients are done under sedation. Very rarely would I do it purely under local anesthesia, because it does get a little uncomfortable, especially the pulling part, the end part. So about 1.5 ml, in each track. Just go a little fast on this. And another thing, you have to know where your thread is going to go. So your local anesthesia has to go there. So suppose you do not fill the local anesthesia under the SMAS, the moment your needle goes there, it will hurt the patient. So you know if the patient has pain, you are in the wrong plane. So either give more local anesthesia or change your plane. A patient cannot have pain if the plane is correct and the local anesthesia is correct. And we always put local anesthesia drops on the exit points, because if we have marked the exit point, we have to come out through that. So that is essential, because that is the marking. We all know the markings disappear when, so just go a little fast on this. So I've just injected 4 points here. Skip this part. I'll talk to you about this later in the day today. Vikas, are we doing a lucky draw for someone today? Where is Vikas? एक बार पूछना उससे please. Okay, so I think at this point, okay, I'll just go back. So why I actually am showing this video, because we've already seen something here. This is just an actual video of the procedure, so there's no fast forwarding or anything. So you need to see how laborious it may be. See, the key problem in these, the only problem you will face in the initial 4 or 5 cases is how to manipulate the needle. Because the needle has to go like this, it has to go like this, it has to go like this. So doing that inside the face takes a little bit of doing, but you'll all get used to it. It's if I could do it, anybody can do it. So I rate myself at around 6 out of 10 as a plastic surgeon. So if I can do it, anyone can do it. Okay, so I think we're going to start with the first needle here. Yeah, so this is my left hand. So if you see one thing here, I don't know if you noticed, I was actually pressing this little hard and pushing the needle, because I wanted to go slightly deep. I do not want it very superficial. And you'll notice something interesting as I do that. Yes, this movement. So the moment you go in, you have to start pulling it, because if you don't pull it, the threads won't pull. That means you're in the wrong place. So the needle is the thread. Remember that. If the needle is not in the right position, the thread will not be in the right position. So please remember that. So at all points you have to pull. So in fact, every 1 centimeter of movement initially, go, pull, because if it does not move, you're wrong. Just come back, start again. More trauma, of course, more swelling, so we all know that. Keep going, keep going, keep going, and at the end, so I'm going to, so as you exit, so what happens is, if you keep going in and just exit out, you will catch the dermis. And if you catch the dermis, that dimple is permanent. So what do? The needle goes like this, then you turn your hand and the needle goes down, and then you turn your hand and the needle comes up. So that takes a little bit of practice. It's very easy to do. So that manipulation has to be learned, and the moment you go vertical outside, your dermis is clear, you will not get a dimple, right? Does that make sense? I hope it does. You will learn this. I mean, you'll do it. So if you see my hand, I'm going to exit now. Yeah. So if you saw my hand, I put my hand down because I want the needle to go down, and then I would immediately come up and just exit. So the hand has to move like this. That's the only way you can actually bring it out without a problem. It does look traumatic, and it is traumatic. So we are not sugarcoating that. Now, next, the thread is going to be introduced into the needle. If you see, so I'm just going to go back. There's something very important that you must know here. Unfortunately, we don't have the thread here. The thread is very abrasive. When you run your fingers on the thread, you actually feel it. It's quite, the cogs are really big. They're very sharp. Now, when you pull the needle, the thread is going to pass through the tissues and out of the skin. If your direction is wrong, it will just cut through the skin, and it will cause you a bad scar here. So how do you prevent that? Let's see if this next action shows that. So the thread is being placed in the eye of the needle. I'm sorry, I'm not fast forwarding this because this is essential. If any one of you is press biopic like me, get someone else to put the thread. You can't see the needle if you're press biopic. I've had to start using loops to put the needles, put the threads now. So if you see now here, can you just appreciate the C movement of my hand. It's a circular motion. It's not this. It is like this. The reason is the thread has to come out like this it will not damage the skin. So that's the thing. And then in the thread there is a central black segment which defines the two directions. So the thread is bidirectional. One of the threads is this side, one of the threads is that side. So the black dot is the center point, that's the fulcrum of the thread. And the next part is very easy of putting it upstairs. So we don't need to see that. But let me just go back. Yeah. So this movement now just continues. So I'm skipping this part. So 4 or 8, 6, whatever you do. In your initial days, you will have, my third thread has always caused me misery in my initial years. That's where the depressions used to be very common. The fourth is very simple to do. The only problem in the fourth I faced was the largest number of hematomas I had in my fourth. Just in front of the ear. So I've had just changed the direction a little bit. But the bleeding was maximum in my fourth. And the third was, for me, it was the most difficult. But now, of course, so again, all of you will have your own experiences. So it's not that he had the third, I don't, I'm better. You all are better than me anyway. Now, there's one thing which I'm doing wrong here is this. My hand is sort of slightly extending. What happens then is the needle curves inside. So you have to be very careful. When you're pushing the needle, your hand cannot go like this. Otherwise, the needle moves inside. So just be little careful of that. So I'll skip this part. This is the point where we are going below the SMUS, into the SMUS from the zygoma. So the second, third, you have to really push to go below. And feeding the tissues. That's what we saw in the morning as well. I do this movement a lot just to make sure the depth of the needle is exactly where I want it to be. There's one key pointer, you could, if somebody wants to just memorize that, all along the length of the needle, the tissue depth should be uniform. You can't have road rollers and speed breakers there. It has to be very uniform. So action replay on the other side. So we'll just, Ankit, इसमें वो pull भी है? वो second part में? वो बैठा के. I've got my WhatsApp open on public. Let's just hope nothing objectionable comes in it. Dangerous. Okay. So next part is the tightening part. I'll just show you how that works. Yeah. Full screen is not happening. Okay, so now what we do is we make the patient sit up and then we just pull and we actually feed the skin. So when we have pulled this thread, we actually pull, push, 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 push. So we're feeding the tissues right onto the scalp upstairs. And then this kind of a dimple is left. You can see these small, small dimples. Now this is harmless. All we do is just take our finger a centimeter or two above the dimple and then just release it. It's very easy, easy peasy, what they say. The Gen Z says, no? Easy peasy. So just fix it here and just release it and it just solves itself. I don't know if I'm doing that here, but yeah. So in fact, if you see the dimple, yeah, one second. So we'll just make this run. So I'm just holding it and I'm just releasing the dimple. So this is something which you will all be doing. For me, at least 6 out of the 8 threads need this release. There. That's all that you need to do. But this finger on top has to be stable because this keeps the thread pressed. Otherwise, the whole thing will come down. Your pull will go away. So you can see the dimple being released. There. So yeah, you can see now it's a normal thing, the dimples are gone. That's pretty much it. There's nothing else that I want to talk about. Complications, hematomas and infection, you have to be a little careful. If hematomas happen, there's nothing much you can actually do. Just takes few weeks more to get okay. I tell all my patients 1 week of swelling, do not keep any important activity in 1 week. At least for our patients, we've had 1 week, in fact even up till 10 days of swelling. Especially maybe if you do additional procedures, you have to wash your head, shampoo everything before, because you're not allowed to do that for a week. No cosmetics. I've had women coming nicely decked up for a procedure. Doesn't work because you've got oil and stuff. You have to just scrub their faces off before, because you've got openings and you've got implants. You would not do a breast implant with makeup all over the breast. You cannot do facial implants as well. So tell the patient nothing on the face, and they're not allowed to do any makeup or anything on the face for the next 1 week. So if they can't, please don't do the procedure, otherwise you'll end up with an infection. So as simple as that. Right? So that's all that I had to put across. I'll quickly, Vikas, over to you. Can we take some questions, or do you want to do, Vincent can, or do you want Vincent to? We can, I don't know if there are any quick questions. We can have a few minutes to do that, because then after that Vincent will talk about how this thread. It's amazing, you know, when you actually talk to his dad, it's so amazing to learn how they. He's such a simple person. I mean, he's such a gentle person, and he really teaches you as if you're his son. That's the beauty of that man. So, and he doesn't speak good English at all, but he still gets the message across. It's all those. It's amazing. I was really hoping he would be here, but it's amazing. And Vincent is an excellent person as well. So he's the CEO of the company. And before he comes up, you wanted to ask something.
Yeah, so do you put any dressings or strapping or pressure garment for the face after?
Is there another mic where we both can handle each question so we can give differing opinions? So I don't. We just clean the face with sterile saline, and we just let the patient rest, because they are under sedation. So 2 to 3 hours we allow them rest, and then they can go back home. Some of them are from outstation, and we keep them with us, but nothing at all. Sorry, I think he has a follow-up question. No?
Would it be a good idea to put a strap like we do for?
So So what we've been doing is, if I do a neck liposuction, I put a chin neck strap. Otherwise, I don't. It's painful to actually. You see, these threads do cause a lot of pain in the post-op period. We've noticed that 2 to 3 days it is quite painful. So add on a strap, it's pathetic. Dr. Rajesh. Do you do any dressings on the face?
No, I don't.
Do you do any sort of antiseptic or something on the face for the holes?
No. Okay, no. Sometimes, according to me, we have to do attention to the patient that have a pet the problem for me of the infection, the main problem is the buried hair, but also the pet in the house. So animal in pet. So because you know they are dirty, and so I think that it's not a problem of antibiotics, creams. It's a question of to say that the patient that in the first few days she must have attention.
Yeah, I think that's good in India. We have children, we don't have any pets. Dr. Raj.
Yeah. When you do the facial liposuction, do you do it in the same setting, or you give a gap and then do the threads? That's question number one. And we find a lot of patients have very, very thin skins, and we find the threads do not hold. Is there any skin prep you do in terms of giving some energies or something where you build up the collagen and then consider the patient for a infinite thread?
I'll answer after. You give your opinion. So first question is, you got the questions.
If I perform liposuction in the same I perform liposuction if necessary, because we put threads in different planes, so there is no problem.
We do the facial liposuction with laser at the same time, because that's subcutaneous and the threads are deep. It doesn't make a difference at all. The second one about thin skin. If somebody has thin skin, Do we build it up with collagen or something? If someone, so sometimes the skin is very thin.
If the skin is thin,
yeah.
if the skin is thin, for me is not a problem if the skin is without elastosis. The problem is the elastosis, the skin damage, not the skin thin. Or the skin thin is not a problem. It can be, it can permits better results because the tissue that are thin are less heavy, so you can perform better results, but without elastosis.
So I have a question,
You will get very good results if the skin is thin compared to someone who's thick.
So I have a question.
Please.
Suppose the patient is undergoing PRP therapy for hair treatment. Can we continue? Can he continue? Or he or she?
Personally, someone is doing any PRPs or stuff on the hair for hair fall. Is it okay to do these threads at the same time?
If I do scaffold,
If a patient is doing PRP
yeah,
for hair fall,
yeah,
can we do the threads at the same time?
yes, why not?
It's unrelated, to be honest. I think your question might be, can we puncture the threads accidentally?
In that area?
No. We are very deep inside. No,
Okay.
no, I don't think that's a problem. Just cut it and let it retract.
That's a long length actually.
I was going to say very Indian. That's a waste. Eat you and use it again. You can't. The problem is you need a bit of, I've thought of that. To be honest, I've thought of that also. Indian, na? So you need a bit of thread attached to the cogs. So I've thought of that.
I have a question to Dr. Lucas as well as Dr. Amit. Yeah, hi. See, can we use these threads to do an eyebrow lift? And if at all, then how it has to be done?
Because the tissue are too thin. So, for example, for the brow lift, according to me, the tissue are too thin in relation to the diameter of the thread. But it's my personal opinion. I know that a lot of surgeons perform eyebrow lift with. I don't like eyebrow lift with the threads in general.
Thank you.
I prefer with the surgeon.
At the entry. So as you enter, you keep going deep. So in fact, the tissues are very, very thin here. The superficial temporal fascia is literally attached to the dermis. So what you might see as being very thin, when you actually put the thread in, you're 3 or 4 layers deep. You want to take that? Where do you anchor the thread? On which layer? Which layer of the face would you anchor the thread up here? Which layer of the scalp do you anchor the thread?
Layer of scalp. The angle. The angle of the scalp. Sorry. Okay. At the beginning, I completely vertical because I don't want to catch the dermis. Okay. So completely vertical. After that, when I'm in the subcutaneous tissue, I'm horizontal.
Dr. Manisha is asking which layer of the scalp is the thread in? What acts as an anchor? Is it the superficial temporal fascia, the deep temporal fascia?
Okay. In this area, do you want to know in what kind of plane am I? But according to me, there is never a problem because the branch, the temporal branch of the facial nerve is a motor branch, it's not a sensitive branch. So if I think that if we should catch this nerve, there won't be a problem because it's a motor nerve, not sensitive nerve.
Priya?
So you said deep to smash. How deep? Deep to smash is a thick layer again. So how deep to smash? That's my first question. And second is, what difficulties would we face when we do a surgical facelift?
So the needle is going below the smash. Can we define how deep to smash?
Yeah, the question, I explained the question before. This is the challenging point of the smash technique. There are some few anatomic point that you have to be sure to pierce. The retaining ligaments. Okay, we are sure that we are in this mass, in the submass plane, when you do the same maneuver that you should do if you perform an high mass facelift. So, at the level of the zygomatic arch, you with the left hand you push the tissues, and you pull the tissues and go with the needle under these tissues. And the retaining ligaments, the zygomatic ligaments, are 4 or 5 centimeters in front of the ear, and they continue for several centimeters. And when you put the needle inside this ligament, you feel, you can hear, but you feel with your hands that you are piercing these ligaments. Okay, there are also the ligaments, the parotid ligaments above the parotids, and there is the cervical ligaments here. It's just a little more dangerous, but there are the masseteric ligaments. I pierce the masseteric ligaments, and I know that I am under this mass, because in the subcutaneous plane they aren't. There are just the retinacula cutis that are completely different.
There's no real way to define how deep, to be honest. You will feel it. See, the thing with tactile procedures is it's an experiential thing. You do it, you feel it. You know you're below this mass because you've already punctured some structures, you feel the resistance. And so there's one movement which I did of feeling the needle. If you've come subcutaneously, you will feel the needle. So then you have to come back and reinsert it. So once you're inside mass, it actually doesn't come out anyway. Now how deep, it doesn't define 2 millimeters, 4 millimeters, what, we would never know that, in fact. The second question you had asked was?
Surgical facelift.
Yeah, suppose a patient undergoes a surgical facelift 4 years, 5 years after these threads. Is it tough, easy?
But I think that there is no problem if he wants to perform a surgical lifting after the threads. You are asking.
Yes.
I think also that the threads should never be removed
yes.
because they are biological stable. So you perform the facelifting. Maybe you can re-pull the threads, maybe not, but it's not a problem. It's never a problem.
Yeah, what are the... Yeah.
So one of the things Priya is basically, see, like a breast implant, these also form theoretically they form a small capsule, and they are inert. They do not create any inflammatory reaction at all, unlike the absorbable threads which work on collagen formation. These threads don't. So you get a smooth plane, and that is the reason why pulling out these threads is very simple. So what is said about these is 10 years later, if you have to do a revision procedure or a facelift, it's easy peasy.
I did a facelift in a patient who had these threads.
Permanent threads?
Yeah, permanent. So my smart was not moving when I was trying to lift it up. So I had to pull out because it was fixed.
Fair enough, yeah.
So I had to
So there was a physical effect of the threads, yeah.
So it was fixed completely.
Very interesting.
Leading to distortion. So I had to pull out everything.
And then you did that.
For my smarts to be more comfortable.
Fair enough.
So could you
Okay.
explain? So
No, not ladies first.
What are the chances of injuring the facial nerve or getting it entrapped?
For me, 0. But have you
But then
noticed any
how-
facial nerve injuries during the procedure?
No, I never had.
But we are going deep, though. How?
No, you're just literally just touching the undersurface of this mass. Facial nerve
Any
will
way
never
to
be injured.
assess that how deep we are going or anything to be safe?
I really don't think you can actually injure facial nerve with this.
According to me, it's not possible.
It's not possible,
It's not
to be honest.
possible.
Yeah, okay.
While pulling the thread.
Can the needle pass through some around the nerve,
But
and can it entrap the nerve?
Okay, you can, from a theoretical point of view, you can trap the nerve with the thread, but there isn't a nerve that is isolated from the surrounding tissue. You entrap the tissue with the nerve inside, and this is not a problem because of the constitution of the needle, of the thread, because the tip are blunt. So, according to me, it's never a problem.
So when we are doing a neck lift with the help of threads, then the entry point will be from here, and then how do we turn it from the center
So
point?
today's patient, if all goes well, she also wants to do her neck. I'll show that today afternoon.
One more thing, sir. Can we only do threads for neck lift and not the face, or you advise we need to do the both?
Have you ever done just the neck
Only the
and not the face?
Yeah, and sometimes I do just the neck and not the face, and just sometimes just the face and not the neck.
Dr. Luca, have you both used these threads for any other indications like the nose or the breast?
Have you done it apart from the
No,
face?
no.
So I have
Face
seen.
and neck.
Because there are a lot of other threads which are used for the non-surgical,
Yeah.
the tip rotation, and people also advocate threads for the breast lift.
Yeah, an acrylic used for the nose, for example, but in a cadaver lab.
Why haven't you used it?
Dr. Rajesh,
Why haven't you used it? Why haven't you tried it?
I really don't like these threads in the nose. I really don't like threads in general in the nose, but it's my opinion.
Dr. Rajesh, when I was in Nice, the very first surgery I'd seen was the nose itself. So they had done it for a tip lift. I would probably not take the risk. See, it's too superficial for me. I mean, it requires any years of experience to enter that region. And the manipulation of the needle here is so tough.
Yeah.
I mean, you hardly have any space to move the needle. But of course, I mean, years of experience, and I would, again, threads on the nose, no.
No.
But yeah, theoretically, yes. I have done it for a facial asymmetries, 2 threads on only one side to match an asymmetry. Breast, so my wife looks after my business, and she said, why don't you do it for the breast? There's such a huge market, they don't want surgery. I said, that's the last time you've asked this question. So never for there's no anchoring point. Where do you anchor it to? These threads are anchored here. Where do you anchor it on the breast? So, and the weight of the breast, these threads are just threads. So I think we are done. Vikas, you want to do the...
Sir,
yeah, oh, sorry. Nandini,
chances of silicone granuloma, and also one more thing, the tensile strength of this silicone should be hard enough, right? That is why you can make this threads so sharp. So there will be chances of fracture of the cogs as well, sir.
I think Vincent would be better able to answer the physics of the thread. So we'll wait for him. You ask him. Silicone granuloma is one question. Is there a possibility?
The silicone granuloma is a problem of the liquid silicone, and it could be a problem of an infection also of the silicone solid. But if you don't have an infection, the problem, the advantage of these threads is that they don't move. So if they then don't move, the fibrosis is minimal, and the granuloma is theoretically not possible.
So Vincent, when you are here, just answer this question during your talk as well. Can it fracture? Can the tensile strength go low? And I think the composition of the thread actually answers that question, but he's the right person to answer that.
Can you hear me? Yeah. So thank you for the question. So first of all, this afternoon I have a presentation covering more precisely the composition of the threads, and so I guess I will answer a lot of questions regarding the materials. So regarding the fracture of the thread, so I will give you some insights about the history of why we created Infinite Thread, but you need to know that the first thing we put on our list when we created Infinite Thread was the mandatory condition that you can remove the threads and that you will never have any breakage of the threads and you will never have any slippage or breakage of the silicone. Because obviously, when you're using a permanent device, you want to be able to remove it, you want to be able to remove it without creating any scar, and you want to remove it completely. You don't want to let part of silicone inside. So for this reason, the traction power of this thread is very heavy, but also the resistance of the threads. That's why we use polyethylene terephthalate for the core of the threads and silicone. So silicone is very flexible, polyethylene terephthalate is not flexible. So you will not break the silicone because it is so flexible and it's also very resistant. So basically, if you want to break the thread, you need to put more than 2 kilograms on the threads. And what you will break is not the silicone. Actually, you will break the full threads, but what will break is in the inside. It's the polyethylene terephthalate. And it's not a big deal. If you break it, you're just doing a little puncture and you extract the rest. What you don't want is a part of the silicone to stay alone as a little, like say, little parts inside, because this would be more difficult. You would need to do a facelift to remove it. So what you want is always the thread to, it will not happen, but if it breaks, it will always break before the silicone to slip. So this is your security. If the thread is breaking in the middle, which will not happen if you're not pulling 2 kilograms, it's a lot. You should not do it. And that's why we do training course, that's why we have protocol. But let's say you do it. It's not a big deal. You can still remove it. And the silicone will not move from the threads. So that's very important to understand that the silicone will not be let alone in the face of your patient. I don't know if I am answering the question correctly, but I heard this was your question, right?
Absolutely.
Yeah. I will go deeper in this during my presentation.
So when we actually tighten the threads, the significant amount of pull which is already put there. So you'll see that in action. Vikas has this wonderful box in his hand. So today, so I'll just run back to GK2 where we just get the patient ready. So one slip out of this has a name who comes with me, and I'll make them do 1 or 2 threads with me today. So this is out of syllabus, but I think this is a good thing. So Vikas, again, please pray that the patient doesn't cancel. I'm literally on my toes right now. So ये सारे मेरे नाम है actually.
And the lucky one is Dr. Nandini.
There you are. See. So Nandini is from AIMS, and you know that question about tensile strength is very Aimsonian. Most other people would never think of it anyway. So.